I'm Alex Fisher. I'm an occupational therapist with the West Midlands Regional Huntington's Disease Service.
Hello, I am Kirsty Page, Occupational Therapist, and I work in inpatient hospital care, and I've also worked in care home settings as well.
Thank you both. And we've just had 4 questions in, so we might get more at the end if we've got time, but let's start with these. So the first question is, a patient that this person's been working with has been motivated to go to the gym, but recently he started declining because he's saying that his legs don't work, and what they're looking for is there a way to get him re-engaged with this activity of going to the gym?
We've pretty much nominated me to answer this question, but I guess we're just going to have to make a few assumptions about this gent. And my assumptions are as follows: that if he is in early or mid-stage illness, the communication of how he feels emotionally and socially will have changed. His complex language to express how he feels will have changed. His volition and motivation, which is sometimes known as neurological apathy, will be changing. So that's the bit that helps us change our wants into do's, as well as his cognitive flexibility. So that's the bit that he is happy to do a few things at once, or not be overwhelmed, or take surprise in his stride, or take on board other people's ideas and go with them, may have changed. This could be set against what other things are going on for him. So what has changed? This can be anxiety, it can be pain, it can be injury, it can be personal change, staff change, approach, or good old-fashioned HD sudden change. So an idea that was okay yesterday is not okay today and often can't be shifted. So for your lovely self, you're going to have to be a bit of a Sherlock Holmes about it. So again, I've made an assumption, and I suppose I can illustrate it with, in this gent's case, say he was going to the gym with a personal assistant, but the assistant couldn't do it, and there was a substitute, and your man thought that the personal assistant was always going to be with him. He might not be able to flex to this change, accept this change, or it's created anxiety which he cannot express in any other way except to say, my legs don't work. So you're going to have to work out what's going on for him, and then work out what you can do from there. Oh, hello, we've got a little question. I'll look at that in a moment. So this is where some of the ideas that Kirsty and I are going to talk about come into. So Kirsty has been uber organized, and she's done a beautiful little presentation for you all. And it has a number of these ideas embedded within it, because this is really problematic in HD and in HD therapy for folk with HD, for their loved ones, for their carers. And so it really is about some really key principles. So it's about knowing the HD person you're working with, not overestimating the importance of key factors such as anxiety, consistent routine, management of change, and cognitive and communication difficulties. Somebody has also asked a question about lockdown, so it's clearly not a COVID-free talk. But Kirsty and I were talking earlier on, and just as we're all suffering lockdown fatigue, so too are folk with HD. So it's often really easy to say it's just HD. Well, yes, it can be, but it also might not just be HD. I guess it's just like a very thick, multi-layered Victoria sponge, and it's working out what's going on. So I hope that gives you some idea, but it will be revisited later on in this discussion. Ooh,
Thank you.
Lynn has come on here on the side with a question. How do I make my husband have a social services carer stroke helper stroke friend service? He says he's okay, thanks. Lynn, can we come back to that? Because I think that's a really, really important question.
That ties in quite nice with,
yes,
so
fits in with the next question.
We've got a question about occupational therapy as well, haven't we? Letting someone in the home. I think, Alex, both of those questions are really suited to you, and they feel quite similar. The question 3 we had on our list earlier as well.
Yeah. Sorry, Ruth.
So so the next one we were going to go, which is maybe a cover all for both of them. Any tips on how to encourage someone with Huntington's disease to even agree to meet an occupational therapist and let them in the door? And I guess by the question that's just come in, it's obviously not just occupational therapists, it's getting anyone in to help sometimes seems like a problem.
Yeah, it is, absolutely. First of all, to say to Lynn and to the person that set this question, oh my goodness, this is so common. And I've literally written so underlined in red. Okay, so I'm going to talk to you about conversations that I have with OTs most days. But I'm particularly thinking about an OT that rang me only yesterday. So a person with HD had been referred to her via somebody else who thought that that person needed an OT. But let's consider it from the perspective of the person with HD. They didn't agree to the referral as they didn't believe there was anything wrong with their function. So this could be the case, or it might not be the case. And this could be due to cognition and problems with insight. And I think Prof and I have spoken on a podcast about this previously, which you might want to access on the HDA website. This person was extraordinarily embarrassed by how they appeared, their communication problem, and this made them more anxious, which compounded any ability to engage. And I think this is really important to say that complex language communication problems and dysarthria really impede the ability to engage in a traditional way. So if you're an OT in the community, you might be expecting a referral and the person who receives the referral to be able to communicate without those difficulties. And that's not necessarily the case in HD. Then this person was increasingly struggling to attend to their organizational tasks. They got into debt. And this sort of translated into not being able to think forward to manage appointments and engage in appointments in a traditional way. So, of course, she kept trying, and the person with HD, kept refusing. In fact, it was compounding the issue because of that, also that fixed and rigid thinking style, which is common in a person with HD. So then, as the OT wasn't able to get in and the person with HD was discharged, because not many of you might know that a lot of our colleagues in the community are given a sort of space of time in which they can connect with an individual, and it's kind of set usually by their management. And so I used to hear things like, and I still do actually, the person with HD is non-compliant or they did not attend. And it was almost made out to be their problem, whereas actually I think it's usually about our systems and not the individual at all. We also have that ethical and consent argument that it is their right to refuse. So you've got to factor all of that in, and I absolutely agree. But if we know that this person may be coming to harm due to problems with their function, and we've got a reasonable belief that due to the stage of the illness, that there can be certain barriers to access, we've got a duty to be a bit more creative and flexible and kind of not leave it to the point where it gets to crisis. I suppose with regards to Lynn saying about making her husband receive help, him saying he's okay, yes, he will do, because that's his default answer. But there might be all of these things going on for him. And it's, again, I would say about being creative. If you can get local services on your side to be creative in this manner, to talk about perhaps cleaners or helpers or holidays, and not use the care language, that goes a huge way. Also, just introducing people very, very gradually in the company of trusted others really, really helps. So I'll go on to illustrate it in this sort of OT example. Kind of, what's my answer? If you get a referral for somebody with HD, be prepared to take time in terms of gaining background, working alongside of people they trust, such as companions or other professionals. I know there's a professional identity thing here at stake, but don't advertise yourself as an occupational therapist. Or if you do, make sure that person knows that what you are there for and what they're going to get out of it. Often, say, for example, a PIP report may actually lead to additional benefits, for example, because you've done a functional assessment. I mean, I'm not really sure many of my patients know what my job title is, and I'm not actually that concerned. Don't rely on them reading their post. This is a real problem. There's an executive function problem here going on, which means that they won't be answering post. They won't be understanding complex language. They'll put it on the side. Send appointments if you must, recorded delivery, so that if they do get them, their attention is drawn to it. That really worked with a patient of mine. He knew when he was going to get a letter from me because it came and he had to sign for it from the postie. Follow it up by phone if you can, or by phone to a trusted other, such as a companion or another professional that they already trust. I mean, it can take me weeks to get to the point where someone trusts me enough to talk to me or let me in. It's like adjusting your approach or your communication style, which you would do anyway with a person with HD. You've just got to start really, really early. I often give it about 6 weeks before I get anywhere in the community. If you're lucky enough to get in, make sure you're on time. Sometimes the anxiety and rigidity is so great that if you're 5 minutes past the allotted time, you may not be allowed to enter. If you do get in, don't try to resolve everything at once. Assess and have a think about what gives that individual the optimal chance. If you're transitioning care from one member of staff to another, plan for this, because you've taken all of this time to get in, so you really must make sure that you can continue with the rapport. If you're on the phone and you introduce 2 ideas with different rules, because let's face it, our systems are really complicated, be prepared to have the phone put down on you as people get incredibly overwhelmed. Try again tomorrow and you'll probably get a different response and an apology. I used to have a lady that used to swear at me and put the phone down on me all of the time, but the following day she'd had chance to process and we started over again. Finally, I've often been successful with hello, I was in the area routine. This probably appears as the complete opposite to what I've just said, but it's very informal and reduces anxiety, and the person won't have had the opportunity to ruminate around you. So it often offers them the chance to see you without committing, and it's something that I repeat a few times. I hope that's given you some idea of, as an occupational therapist or any other professional, getting to see somebody in the community.
Thank you, Alex. And the next question that we had is, what can be done to encourage, and what are the benefits of regular exercise? And for this person in particular, they were talking about someone who would be doing seated exercise.
Over to you, Kirst.
I think what I'd like to do, Alex, Reeve, if that's okay, is do the presentation and then come back to that, because we're going to talk about we had two questions. That was one of them we wanted to come back to, because there might be other questions as well about, very practical solutions, but there's lots of resources regarding that question. So can we come back, if that's okay?
Yeah, of course. So are you going to pop your slides up again?
Yeah.
And then, brilliant.
Okay. So let me know that you can see those.
It's coming through. It's not there yet.
Okay.
There we go. Perfect.
Okay, so we want to, first of all, just think about the benefits of engagement for people with Huntington's disease. There's a lot of research that shows that physical activity slows down the progression of Huntington's disease. And our colleagues in physiotherapy have done a lot of research and studies. And that's kind of why I wanted to talk and then go back to the question about the benefits of exercise, because we are going to say it's really, really beneficial for that person to exercise. And we're going to give you some links to finding activities for someone who is sitting down if they can no longer do exercise in standing. But other reasons why engagement is so important is encourages our self-worth and purpose. It gives us a reason to get up and start the day. And then once the day is started, if we can be doing physical skills to keep our independence and keep our function, that's fantastic. And also to reduce boredom and reduce depression. So some of the benefits of engagement: if someone's not engaging, it could be due to poor drive. And you've touched on self-neglect a little bit, Alex, when you talked about patients in the community, people in the community not opening post. I'm sure you've got lots of examples of people who aren't paying their bills, having problems with benefits, they're not managing their finances. I've got certainly examples of people who can end up coming to a care home or hospital setting due to self-neglect, and that could quite often is due to around hygiene and personal care, or it might be eating and drinking. Another risk of not engagement is poor mood, depression, increased anxiety and aggression, and then, as I've touched on, support networks breaking down. So as occupational therapists, Alex and my role are quite different depending on where you're working, in the community or in myself in a specialist hospital where someone has come to us because care's broken down in the community, or it could have broken down in a care home as well, and someone needs the full multidisciplinary team to support them and to help with engagement. Okay. Before we talk a bit more about the features of Huntington's disease, which impacts engagement, I started thinking about how I engage with activities from a personal perspective. And there's a picture of how I like my cup of teas. And I drink tea throughout the day. I love a cup of tea. And I was really struck last year when I really struggle to do a task that I do every day and I don't think about. And I guess if you all just take a minute to think about when you last made a hot drink, and I suspect you didn't put too much effort or thought into that. It's a task that has become automatic. For me, beginning a lockdown, my daughter ended up in hospital during the COVID pandemic, and I had a night of no sleep, saw her being put in an ambulance, waiting for A&E, her to let me know what was happening. That morning, after no sleep, I cognitively took 2-4 attempts to make a cup of tea. My planning, my sequencing, my ability to recognize that it was going wrong, it all went. I made 4 cups of cold tea before I gave up and someone else took over. So that really made me think, an activity which should be so easy suddenly became really difficult. I've heard people talk about suddenly they can't use their arm, they've got a trapped nerve, or they've broken a bone in their dominant hand. Physically making that cup of tea is going to change. And I think when we're thinking about Huntington's disease, and Alex and I are going to try and break down the physical components of Huntington's disease, the cognitive and the behavioural. which in real life, all of those factors are interconnected and going to make a difference to how someone's engaging in a task. But I think we must try and bear in mind what might be a simple task for someone is probably greatly harder than what we would perceive it to be, particularly if someone can't tell us. We can't begin to really understand how hard a simple task can become. So let's move on to the individual features. So just want to touch on cognitive features which may impact on engagement. So that's the thinking and the planning that we do to engage in an activity. And I believe, and I've certainly heard other professionals talk about the cognitive features being the biggest challenge for a person day to day. A person might not even be aware of the physical features of their movement disorder, and might not be that concerned about they are not engaging, but cognitively that's really difficult for carers and the person. So areas which affect engagement, slower thinking and processing of information. So understanding what's happening around us, what we're seeing or what we're hearing or what we're smelling and touching, that becomes slower. So to recognize what's happening is taking slower to understand that. Memory in HD, memories aren't lost, so such as dementia, memories are still there, but accessing them is harder. So recognition is easier than recall. So we might recognize that person, but to remember their name or to communicate can be harder than actually recognizing. Difficulty in multitasking. I talked about that with the cup of tea, but doing one thing at a time can become harder, and attention might be more selective. So the person might focus on one part of the task and not notice what's happening around them in their environment. So, for example, I might make a cup of tea while thinking I need to add something on my shopping list and hearing the door go and recognizing that's all happening at once. Where for someone with HD, all their attention might be on filling up the kettle and not what's happening around them. Another feature is difficulty planning, organizing and sequencing. Again, because all the features are slower. So a complex task, remembering what to do, organizing what happens next becomes slower. And due to the neurological changes in HD, we talk about Jimmy Pollard and can't wait. So quite often with HD, someone's immediate needs need to be met immediately. So we say they can't wait. Someone wants a cup of tea, they want it now. Not in terms of when I'm at work, not after handover, not after I've gone and put the towels away after getting someone washed and dressed. They want the cup of tea, they want it now. So we need to remember that. I'm going to go on to some features to consider, and Alex and I are going to jump in here in terms of how we can promote someone to engage. So we talk about consistent daily routine, and I think that structure is important for all of us, but I think very much I think about daily routine in a care setting, but I think that's just as important at home to get routines embedded really quite early on. Would you support that, Alex?
Definitely. I think one of the questions was how do you maintain motivation in lockdown, I think it was. And I think I want to go back to on the HDA website, there was a beautiful piece by an older gentleman, an older carer called Graham, who was looking at the importance of consistent daily routine for his wife in lockdown. And I would suggest that everyone have a look at that. It's a very small blog, and I think it's divided into about 10 points, but it actually involves very much about that consistency of daily routine. What we're almost doing here is we're like matching the rigidity in the HD brain with rigidity outside. So you're actually optimizing people's skills by assisting them in a consistency and consistent daily routine. Gentleman yesterday who I went to visit, who's got HD, but has also just come out of hospital having had COVID. So he's now on oxygen. For him, that has actually made some of these cognitive problems much, much worse. And so he's having to pace now to manage his fatigue. And one of the ways that he can do that is through a consistent daily routine and quite a rigid structure. Helps everyone around him also know what's needed. And therefore, whilst it might be difficult to set in play, it's actually really has huge benefits for everyone, not just him. And sorry, I banged on a bit, haven't I?
No, but that's fine. And it's, I'm going to almost contradict myself. So I'm saying, yeah, that consistent daily routine is really important. And then I'm also saying if someone wants it now, someone wants an activity to happen, they're going to want it when they want it. So it's really hard for family members, for carers and staff members you want that structure in the background, but you also need to consider that someone maybe can't process or understand that you need to finish what you're doing because their need is the greatest need. I've put choice. Choice is really important, but think about how much choice you're giving. If someone is struggling to process all the information that you're giving or the visual information in the environment, you might want to limit the choice. Not quite choice, but I certainly see in the environment that I work, for a lot of people, the environment, if it's quieter, there's less going on, the TV's off when they're doing focusing on a task like eating and drinking, that makes it easier than having a really busy environment with too much choice. Bite-sized tasks. If a task, I'm talking about breaking down a task. So if someone, rather than saying it's time to get showered now, you're actually breaking down the task in getting out of bed, collecting your clothes, collecting your toiletries, and again breaking down the task into washing and dressing, so you're not expecting everything to be done at once. Visual cues such as having lists, calendars, notes. I love what you're suggesting, Alex, about the post. If the postman knocks on the door and you have to sign for that post, you've got that visual cue that the envelope is there in your hand, as opposed to it getting lost, ending up on the doormat and getting lost. And we talk about verbal cues, and that's us telling someone what we want them to do next. So for example, come with me. I'm asking someone to go to the shower. Come with me, Alex. Can you sit down, Alex? Can you take off your shoes? So it's the verbal information that we're giving. Simple questions and conversations. So I talked earlier about memory and recall. Recognition is easier than recall. So rather than me on a Monday morning coming onto my unit and saying, what did you do at the weekend? It's going to be easier for someone with Huntington's disease to answer a simpler question. Did you see your family at the weekend? Did you see your brother? Family is not a great example at the moment because of COVID, actually, is it? But it's trying to not ask such a big question. So it was sunny at the weekend. Did you go in the garden?
It cuts out the abstract. I think it's really important when we talk about executive dysfunction. So that's like the conductor of your orchestra, the chief executive of your company. Usually the person without HD can multitask, as Kirsty said, but actually your chief executive goes a bit on strike when you've got HD. So actually that executive function is like the ability to pull abstract information from all of the different parts of your brain very, very quickly. What you're doing by making the adjustments when you're talking to an individual or having simple conversations is you're cutting right through all of that confusion. If you like, you're acting as the chief executive of the company, as the conductor of the orchestra, and you're really helping that person optimize their function.
Yep. And then allowing time for response, and it's very much knowing the person you're working with, but it can be quite surprising how long it takes for someone to process what you've asked. So give time and don't try and fill the gaps, which is quite hard. But you often can find you've asked a question. Would you like to? There's no response. Shall we do this? No response. How about I? No response. And it's really hard as the person communicating to slow down, be patient, and give time for a response.
Golden rule, 10 seconds. One thing, 10 seconds, definitely.
And
don't fill it with your stuff. It's not about you necessarily. It is actually about, I suppose, really focusing on good quality, positive interaction.
And once you've had that interaction, and I've learned this the hard way, is if you're asking someone to do something, be ready to do it. I've thought I've got someone wanting to engage. I've said, shall we come with me? Someone's come along to, for example, go out in the community. And then I've thought to myself, oh, I need to get the money. I need to get a member of staff to help me. Is the transport ready? And in that time, I've lost that person's engagement. Be ready is that hurry up and wait. If I'm taking someone out or taking someone to the garden, everything needs to be set up ready. If I'm taking someone in the shower and that person says yes or follows my prompt, you need to be ready to go. So be ready, get everything ready. And that same if you find a routine that works, keep with it, be consistent. So it's that, be ready and then wait. And what's the best time to be asking someone? Is the better time in the day when they're less fatigued? I quite often will let someone know what's planned before the activity is going to happen. So they've got time to think about it and process. And then when I come back, the activity is ready to go.
I think in the community, that's really, really important as well, because it offers the person, again, we're talking about optimizing the person's function. We're not taking away here, we're optimizing the person's function. So we are trying to give autonomy and choice. And so planning is really, really key because it allows that person to adapt in their own time. Because sometimes you can drop stuff on people, and of course life does get in the way, and it just sometimes just happens to. But if there's a massive change, it allows that individual to adapt and also to have a little bit more control and to show their skills, it's often the life gets in the way stuff that then causes the greater difficulty for folk with HD.
And another thing which, it's I guess a core skill for occupational therapists, but it's really important for all of us working with HD, is that what we're asking of someone is set up for their level of cognitive ability. So Alex and I have talked about, and I think it's on one of the slides actually, about Jackie Paul. And
do you want to fast forward it a little bit then? Because our time is ticking on, isn't it? So
I don't know whether okay,
let's-
we'll come back to Jackie, but it's
Yeah.
about the right activity. So physical features which impact on engagement, fatigue, it affects us as well, doesn't it? But fatigue of HD, the environment, I've already touched on the environment and the noise and the sensory aspects of visually what you can see, what you can hear. Equipment, having the right equipment to be able to do what you want to do. The length of activity, the time of the activity, the time of day. Is it just before lunch when the person's really, really hungry? Is that the best time to try and engage them in an activity? Likewise, often after lunch when that person just wants to rest. And communication style and aids, very much the way we calmly and clearly communicate with someone. Let's go on to strategies to consider. So fatigue management, understanding the person you are working with, you're caring for, and recognizing fatigue. It does surprise me how fatigued someone is from doing an activity which can look quite easy to them. I've got a lady who's able to communicate that if she's planning to go into town, she'll get up, have a lay-in the day before, and she'll get up early for her trip into town, and then the next day will be mostly spent in bed because she needs that. She's able to express that she needs that rest time. If she couldn't express it, we'd perhaps think that it's apathy or depression, but she's able to say that she needs that time. Do you want to talk about the pool? I've put it there, the pool activity levels, Alex.
I think, okay, yeah, I think earlier on, Kirst was talking about making an assessment of how that person can engage with activity depending on their level of cognitive problem. And that might sound a really, really complicated thing to do, but there was an occupational therapist called Jackie Poole who created what she called the Poole activity level, PAL, for occupational profiling. In other words, finding the level at which your loved one can engage, because people have different levels of cognitive impairment, which impacts on their everyday function. And this resource here that's on the screen guides you through it. You don't need any special training to undertake this. And it is in the Royal College of OT's nursing home engagement guidelines. Highly recommend it. So it essentially takes into account your loved one's history and their likes and their dislikes, and what's meaningful to them. And it literally translates it into a plan. And I think the really, really important thing here is that actually sometimes it's about looking at occupation in a different way. For those of us with a non-HD brain, we take it for granted. We take it for granted that we can multitask. But actually, as our cognition deteriorates, we might struggle with initiating and terminating an activity, for example. And what this lovely tool does is it breaks it down so that you can understand that as a caregiver. And it gives you some really nice ideas. And it's also about seeing occupation and activity in a different way. So I was in a nursing home only yesterday, and the staff were very, very keen to engage the gentleman in their huge activity timetable. But it was at a level that the gentleman could not engage at anymore. And so actually it was about the simple things for him, the sensory things. So in other words, touch and smell and sound. And it was about at his level. So 5 minutes was enough for this gentleman. And then he had a break. So it's about thinking about occupation differently, not being active 24/7, because let's face it, none of us really are. And so it's really, really important to think about it differently and break it down.
Thank you, Alex. I'm going to move swiftly on to behavioural factors. So someone's change in their behaviour or their mood or their personality. Person with Huntington's disease may have little awareness of their behaviour. This can be really distressing for carers. The person may have no behavioural problems, or there might be some mild problems. However, behaviour can also lead to significant disruption and breakdown in family life at its worst. So impacts for engagement would be depression, poor drive, poor initiation, irritability and aggression. So if someone is depressed, they're not going to show interest, pleasure in what they're doing, and they are going to withdraw. I've put impulsivity down there, someone rushing about what they're doing and with no apparent thought of what they're doing. Initiation, what I mean by that is someone not being able to start something. So someone might need that prompt again. We're talking about prompting, or the environment to be set up to help them start the task of getting up or getting dressed or going to get something to eat or drink. Once they've started the task, they might then be able to continue it. So strategies, try and understand what the triggers are to a behaviour. If you can understand what the triggers are by observing what's happened before, then what the behaviour is and what happens after the behaviour, you might start get a picture of why that behaviour is happening. Work with people in a calm, controlled environment. Think about your physical self and how you interact. We've got regular routines again, so the person with HD knows what's happening, knows what's coming next. There's no surprises. And I've put avoid confrontation. So in terms of us, we're not going to argue back with someone, that we're going to avoiding confrontation with folks. Okay, I'm very conscious of time, and I want to make sure we've got time for questions and answers. So I'm going to jump to optimizing activity, and I'm just thinking about the people I work with and trying to get someone to engage and interact. Whose goal is that? Is that mine? Is it the care staff, or is it the person's goal? Does a person, as Alex said, want to be engaged in activity 12 hours a day? What's important, meaningful for that person? So I was describing to Alex a patient that I've worked with who I've seen him walk down the corridor to the dining room with his T-shirt on back to front. Do I intervene or not? I choose not to. He's functionally had a go at getting dressed. That was what he wanted. It doesn't matter that his T-shirt's inside out. I've got another patient who wears his shoes on the wrong feet. That's a bit different because there's a risk involved with that. But what's meaningful, we had another patient who was really struggling to engage with us, but actually we found a way in. He liked dogs, and once we brought a pat dog onto the unit, he got up and wanted to spend time with the dog. So we used that as a way of building up a rapport with him. I made a note when you were talking, Alex, how important trust is, and how that, you said about 6 weeks to get to know someone. That's really difficult in a care environment when someone hasn't engaged for so long, and as a team we're trying to build up that trust. So it's thinking about whatever we want, we're asking of someone, adjusting the activity for the cognitive, physical, behavioural features of HD, and try again. Every day it will be different, and there's no right or wrong way necessarily of trying. But if it doesn't go well today, doesn't mean it won't tomorrow. And you might find a really good solution that works today, and it might not tomorrow as well. Keep going. It's really a real complex area, and And we have broken it down, but of course all those factors intertwine together.